Thank you, organizers. And I'll be speaking on exon 20 insertions and the role of Amivantamab in it. And let's go to. We all know that EGFR mutations are one of the most prevalent driver mutations. And when you look at this, when you look at the EGFR mutation as a whole family, exon 20 insertions come anywhere between 1 to 10% of the whole mutations rates. It's interesting that if you start classifying the uncommon EGFR mutations, in most of the papers, exon 20 insertions in the uncommon mutations would be comprising at least one third to one fourth of the whole bunch of mutations. Now, when we talk about exon 20 as a exon 20 insertions, we understand here that when we're talking about, we are looking at focusing on the exon 20 and we're talking about insertions. Now, what happens differently when we have an exon 18 or exon 19 or for that matter exon 20, 21 point mutation as opposed to when we have an exon 20 insertions. There is a loop here which is highlighted in the color of, I think that's yellow, then blue, and then a few more colors which I'm not very clear with. In this loop, there is a conformational change happens when you have this insertion coming in. And when the conformational change happens, this you cannot, the first generation, second generation, and even the third generation TKI cannot reach only up to this point. And a lock-like setting happens which activates the ATP continuously. And because of which the continuous signals are being going for proliferation. And because this lock-like situation happens and this allosterically this site cannot be approached or the molecules cannot reach it, the response rates which are there with other TKIs in this setting are quite less. Now, what is the incidence of this exon 20 insertions? We see this incidence is variable across the world literature. And out of all EGFR, it comes anywhere between 2 to 5% of the incidence. Now, this is just a more detailed of what I told you, what happens with respect to the exon 20 insertions. If you look at that exon 20, the three regions, let's call that as a yellow color. The yellow color is the helical region, then the near loop region and the far loop regions. And if you see this, the most of your insertions would allosterically actually modify the helical region, and few of them do it at the near loop and far loop regions. And because of this allosteric conformation which happens at this site, the continuous ATP kinetics gets locked in an active state. Now, there are multiple types of exon 20 insertions there. This is an ever increasing list. The more and more you go into NGS and the more depth you look for, you will keep getting more and more insertions done. The two most commonest types are which I have highlighted. We also need to understand there are some types of exon 20 insertions which are actually sensitive to the first generation TKI also. But today we will be talking specifically about the commonest type, which are not very sensitive to the routine TKI. This is what is the response rates which you get when you give your first generation or second generation TKI, when you give it in the common EGFR sensitizing mutations, about anywhere between 60 to 70%. And that is what the response rate, which is more or less in and around 10% and higher amounts of 20% which you get. Understand that the response rates that have come at around 20% are all those studies in which exon 20 insertions has been as a compound mutation with some sensitizing mutation. If you have an exon 20 insertion, which is a singular mutation, most of the time the response rates are less. The median OS in this patients is not great. The median PFS is also not great when you treat these patients. And treatment options in exon 20 insertions are very limited. Most of the people would give platinum-based chemo, give TKI, but your response rates, if you see here, in most of the situations will be in the range of around 10%, and the PFS in and around of 4 to 6 months will be your PFS, whether you use it in first line or you use it in second line. This is the data just to show you that how bad they behave with respect to the commonly found mutations which are sensitive to the routine TKIs which we give, both with respect to PFS and with respect to the 5-year survival rates. So we can sum it up by saying that when you have an exon 20 insertions, the incidence is variable. It can be anywhere between 2 to 4%. They do not respond to your first generation, second generation, third generation TKI. We need some other forms of therapies. Platinum-based therapies do not give you good results with a median PFS reportedly between 4 to 6 months. And at the end of 5 years, with other TKI, you have patients living for around 30 to 40%. Here, only 8% of the patients go ahead. Now, do we have data from India? And we do have data from India. And the first author is actually sitting here, Dr. Shruti, which we looked at exon 20 insertions from the Indian population. And you could see that the PFS in our patients was only 6 months. And the median OS was 15.8 months. We had used first generation TKIs largely in these studies. And it had minimal response. We went ahead and again compiled in detail about exon 20 insertions. And what we saw that most of them presented with much more disease burden, the poor performance status. Many of them never used to receive any form of therapy. And in exon 20 insertion specifically, our overall survival at Tata Memorial Hospital was dismal, and it was only 5 months. And if you look at data which has come from India, what is the incidence of exon 20 insertions in India? It ranges with somewhere where the international data is there of 2 to 5%. There are quite a few publications have come, varying from 1 to 8%, but on average, it is around 4 to 5%. And this is just to tell you that when these exon 20 insertions come, even if you would see that the high amount of patients who come in PS2 and a high disease burden with respect to patients who have EGFR ALK negative versus patients who have. And this is the Tata comparison of what happens in exon 20 with respect to the other. And you could see that OS is only 5 months as opposed to 15 months in the other situation. And as I was clear at the start of the talk, the incidence of exon 20 insertions and types actually would depend upon what testing you're doing. The higher the use of next gen sequencing is done and high throughput outputs have been used, you would tend to go to find more and more of these insertions. So now, if you have a patient who has exon 20 insertions, what would be the therapy would you give? There are agents like Amivantamab I'll be discussing today, but there's data for mobocertinib also, there's data for poziotinib also in this. I will be focusing today on Amivantamab. So what is Amivantamab? Amivantamab actually is a bispecific antibody. It's an antibody against EGFR and MET both. So it actually takes not only control of EGFR, but also takes control of MET, which is one of the commonest off-target mechanism of resistance, which happens when these patients do progress naturally. Now, how does Amivantamab help in this? 3 mechanisms of actions. Because it binds to the EGFR molecule, it makes a neoantigen and attracts the other immune cells to come and bind this and destroy the cells. That's one. The second is the receptor when it binds with the receptor will be gets degraded. Something which is called as provocytosis, where the receptor gets lysosomally degraded. So actually the higher amount of expression of EGFR and MET gets decreased in this. This is just giving in much more details how when you use Amivantamab, you would have more immune cell directed activity. That's only one thing which I would try to focus here. If you look at the antibody structure of Amivantamab, this is the Fc segment has low fucose, and if any antibodies Fc segment has a low fucose, it becomes a better antigen, and it attracts more amount of immune cells, which this antibody does. So there's high chance of immune cell directed activity against this antibody. This is just again a diagrammatic representation of how the receptor degradation happens, with which this activated receptors can get inactivated. So now you want to give Amivantamab, how do you give it? I have an experience because I'm running not only 4 or 5 studies of Amivantamab at Tata Memorial Hospital in multiple settings. Amivantamab, we must remember that the dose changes according to the weight. If less than 80, the dose is different. More than 80, the dose is different. You need to have something kind of a loading, which you do in the first month. You give weekly injections, and then it is 2 weekly. This drug, when which was given initially in its phase 1 studies, actually led to a, I won't say high amount, but a pretty decent amount of hypersensitivity reaction, which we call as infusion-related reactions. So, and hence, the company overcame that not only obviously by giving Avil or any anti-allergic medications, but they also split the dose. So the first dose gets actually split. So if you're going to dose a new patient, you give around 35% of the dose is given on the first day, and the initial infusion rate is only 50 ml per hour. After 1 and 2 hours, if the patient doesn't have a reaction, you step it up to 75 ml per hour. The remaining dose actually is given on the day 2, which is the next 70% of the dose. Now, when the study came to Tata Memorial Hospital, by that time, this initial reactions had already happened. So we have been following this modified dosing also, and we didn't landed up much with any infusion-related grade 3 or even grade 2 reactions in our patients when we have given amivantamab. So that's one suggestion from my side, that follow this very strictly, because if it is not, there was a put 16% chances that the patients would have infusion-related reaction. Now, I'm not going to describe this whole whole structure for this trial. What we must understand in this, that I will be focusing on the group D, which is the EGFR exon 20 insertions. One of the development of amivantamab has amazed me. This company has come out not only with exon 20 insertions, also in first line setting, post progression in the first generation, second generation setting, post progression, post third generation TKI setting. Patient has MET amplification in that setting, and each of this are independent phase 3 studies which are going on at present. In fact, I must congratulate the company that's far smarter. It has also come up with a subcut regimen, and there's a phase 3 trial which is at present we are it's going to start in Tata, in which the subcut regimen is going to be compared against the IV regimen. And even in the subcut also, they have another bifurcation afterward. The subcut regimen will be of 2 types, which one would be manually administered, other would be administered by a what we could say a subcut infusional device, which would be an automated device. I have hardly seen any company doing phase 3 studies for such kind of infusional administrative purposes. So we'll focus on what happened in exon 20 insertions. And these were the patients which were taken in group D. And remember that these were the patients who had got previously exposed to therapy and then were taken in this trial. And what we see here is it's a pretty big data. It's a data of 81 patients. And if you see that the median number of lines of prior therapy was 2 in this patient, that most of the patients had at least exposed to two lines of therapy. And if you could see the previous systemic therapy, nearly all patients are post-platinum, and good number of these patients have been exposed to even immunotherapy, and after that even to EGFR. So we are talking about a population, exon 20 insertion population, which is bad, and in a setting where quite a few patients are second line or beyond. And if you look at this TRAE, which is actually treatment-related adverse events, TEAE is treatment emergent adverse event, which means that any adverse events comes, the PI needs to decide whether this was because of the therapy or not. So we would focus on TRAE, which are the treatment-related adverse events. You could see that the grade 3 AEs were 16%, but discontinuation because of AEs was seen only in 4% of the patients. Yes, there were dose reductions required in another 10% of the patients. And if you look at the infusion reactions, this comes down to only 3% in grade 3 or above. Because this drug has both components, EGFR component and a MET component also, you will have EGFR specific side effects like rash, paronychia, stomatitis. You would also have MET specific side effects like hypoalbuminemia and peripheral edema in these patients. Frankly, in what patients we have treated, not a big number in Tata, we have not seen hypoalbuminemia and peripheral edema coming up in this patients. So the actual worry is the rash which happens in this patient and paronychia which happens in this patient. In fact, one of the patients in TMH in that we had to stop because of a lot of paranoia the patient had, and the patient did not wanted to continue therapy further because it just kept coming after every cycle which was been given. Now, let's look at what is the response rates. And if you remember, the response rates in first line setting when we had given was less than 10%. If you had compound mutation, it went up to 15 to 20%. What I mean by compound is you have an exon 20 insertion. In addition to that, you have a rare EGFR mutation or any other mutation. You would see that the response rates here is 40%, but we need to keep in mind this patients are post-platinum, post-IO, and post-EGFR. Quite a bit, the clinical benefit rate was around 75%, which is 3 out of 4 patients actually benefited. That's not a, this is an odds overall response rate chart. This is not a, this line is not the line of forest plot where you say, if it is here, this benefit it isn't. It's just showing that the response is 40%, and across anything you see, the response rate remains around 40%. And if you look at the response over time, you could see that the response is pretty durable also with Amivantamab. And the 63% of the responses actually continue beyond 6 months, which actually is impressive in third line and beyond settings for any. And if you could look at the median OS was around 23 months. If you remember, if you could recollect the data from Tata, the median OS was 5 months, and the other data in which the median OS is to be between 8 to 10 months in this. Now, the interesting thing is, how does this response is there with respect to at what part of the exon 20 loop this insertion happens? Now, not much to go about. Helical region, it is said that is 100%, but that's only one patient. So I won't make any much conclusions that. What it shows is that if you look at near loop or far loop, more or less the response rates are there around 40 to 25%, and the CBR rate is 70 to 75% in this. So at present, irrespective of whatever type of exon 20 insertion, you can treat them with Amivantamab. So the summary was that it has less amount of side effects, 16%. Discontinuation rate was only 3%. Reduction was required around 10% of patients. It gives you a response rate of around 40%. A clinical benefit rate of tends to be around 75%. And has a very good anti-tumor activity against all variations of exon 20 insertions. And this could be a potential target for to be used in exon 20 insertions. Actually, this data for this is coming even for at present studies are going even for the first line setting and post osimertinib progression setting in this situation. And I think there are only 2 minutes left to show you the data of CRSF with respect to the other, that if this was a real world analysis, patients of exon 20 in other prospective databases were taken and they were matched against patients of CRSF. So this is not a randomized comparison. This is a retrospective matchback kind of comparison. So it has its own bias. What it shows that, what I was been telling, that if you control, if you see this match data, it seems that the patients benefit more with Amivantamab, both in terms of response rate, PFS, and overall survival also. And again, the conclusion remains that your overall survival and PFS improves if you use Amivantamab. That's all from my side. If there are any questions specifically, I would be happy to take. If not, thank you.